Good afternoon, and thank you for having me here. It's lovely to be back here talking to you all. I've called this presentation Breaking Down the Behavioural Biomedical Distinction in HIV Prevention because I think it's important that we talk about preventing HIV in a broad sense rather than carving it up into little niches. I think it's particularly important to note that no one prevention strategy will be effective, appropriate or acceptable to everybody. Now, that's not just in the brave new world of biomedical prevention, that's now. No one prevention strategy is appropriate and acceptable and effective for everybody. And introducing different kinds of modalities of prevention doesn't mean that you're going to come up with something that is instantly acceptable and effective for everybody. Another concept that I think is really important is that life stages are important in HIV risk. That people go through different stages of the way that they are interacting sexually and socially, and that at different points in those interactions, different kinds of biomedical strategies might work better or worse for people. And so having access to a range of different prevention strategies potentially gives particularly the young gay man an opportunity to think about the way he's going to approach the way he's going to approach HIV prevention in different ways, depending on the kind of relationship or relationships that he's in, the kind of sex that he's having, the serostatus of his partners or partner, and actually make decisions that are appropriate for him and that are decisions that he can have some kind of faith in. The next thing I'm going to do is I'm going to tell you a whole lot of things that you know, and I hope you enjoy that. I hope that makes you feel clever and good. The first thing is, this is a slide that I've borrowed from Robin Shattuck, and I think that we all recognise this, that to have highly effective HIV prevention is not just about people using condoms, it's about a whole framework, and this in many ways talks about the sort of way that the Australian approach to HIV has been, that it's involved social justice, human rights work, it's involved legislative structural change, it certainly involves some behavioural change. Definitely, we are reaping the benefits of years of treatment, of antiretroviral treatment, and also effective treatment for sexually transmissible infections. Where we haven't really come very far at yet is the biomedical strategies down here. Although when I say we haven't come very far, in Australia we've had access to post-exposure prophylaxis for quite a while now. So currently, we do this kind of highly active HIV prevention, but one area that has really not been optimised at the moment is this one down here, which is adding in biomedical strategies. Although if I can just point out that treatment, antiretroviral treatment is really a form of a biomedical strategy as well. So what has happened recently? As you can see, this is just a chart that shows you when we've had different biomedical prevention strategies proven. As you can see, male circumcision, that's what that MC stands for, is in 2007. It's the first thing that came along since 1994. And obviously male circumcision is an extremely flawed notion for a gay male epidemic in which people are, the proof isn't there that it works to the same extent when you're talking about anal sex as compared with vaginal sex, and B, when you're talking about people who are versatile in their sexual roles, it's just not going to have the same kind of impact. But the first time we do start, in 2009, we got that strange result in Thailand of the vaccine that seemed to be a little bit protective, but that's a highly contested result at this stage, so it's not particularly one that we're going to go anywhere with. However, pre-exposure prophylaxis is something that basically has been shown to work in men who have sex with men, and it's something that we have to consider in the way that we think about biomedical prevention and HIV prevention broadly, as is antiretroviral therapy for the index partner. Now, I've said earlier that we are already seeing, the kind of impact that good antiretroviral coverage is having on ongoing HIV transmission. We don't know the extent to which it keeps seroconversions low, but we can estimate that it certainly does something there. So why do we need to think about HIV prevention in a new way at the moment? And the reason for this is on this graph, which I'm sure is very familiar to you. It's from the Kirby surveillance reports. As you can see, we've been looking at annual incidence of around about 1,000 a year. So that's 1,000 people, and of those 1,000 people, 83% of them are men who have sex with men, or gay men and men who have sex with men, or however you want to see that particular one. Personally, I like the gay men and men who have sex with men, but I know that there are different views on that one. So 83% of those 1,000 people are men who have sex with men, and they're basically the core business for HIV organisations in Australia at the moment. The reason that I'm showing you this graph, this is the prevalence of unprotected anal intercourse with casual partners from 2001 to 2010. And as you can see there's this thing of between about 16% and about 25% of men are having unprotected sex with as shown in these snapshot surveys around the country. So it varies a little bit, some of the lines go up and down a little bit, but there's that little core there. So those are men that have prevention needs that basically aren't being met at the moment, except maybe in an indirect way if that person of unknown serostatus that they're having sex with is on treatment. If he's not on treatment, that person at the moment, at that percentage of sexual exposures, he has no particular prevention happening if he's not using condoms there, which is what that slide shows you. This slide here shows you treatment uptake of people enrolled on the HIV Observational Database. Now, the red circly line is none. So it looks like currently around about 13% of people who have HIV and who are on that database aren't taking any treatment. That's probably a reasonable thing. It's important whenever we talk about strategies around increasing treatment access that we talk about that in a way that is empowering for the person who's going to be taking the treatment. No person with HIV should take treatment until he or she is ready to take that on as a lifelong commitment. So I don't want to have people think that I'm advocating for anything other than that. What you want to be sure is that people have access to the knowledge about what treatment can do for them, about knowledge around how it might help them to protect their partners. And so certainly those conversations should be taking place, but we may still continue to see that around about 13 to 15% of people continuing to choose not to take treatment for a while until a better drug comes up or until they feel more secure in their lives to actually do that. The little pink line there is a funny one because that's mono and double therapy. Now, that's interesting that people would be on what looks to be not highly active therapy there. And that is something that should raise questions for people who are working in community organisations and also for clinicians to think about whether there is this group of people here who might be taking anti-HIV therapy that's suboptimal. Because clearly that's not a good idea. If you're taking therapy, it should be maximally effective therapy and it should be aiming at suppression. So that's another thing that's part of HIV prevention today, is looking at suboptimal therapy in HIV positive people and making sure that HIV positive people are actually being encouraged to take the therapy that's going to be best for their health. Okay, so pre-exposure chemoprophylaxis, which is a very long way of saying PrEP. I know that you've all seen this data before. Basically, you've got a 44% reduction in HIV incidence in the men who were taking the tenofovir and FTC combination. It's important to note that the men in that study had access to the highest standard of care that they could. These men were also offered PEP for exposures. So they were able, if they knew that they'd had an unprotected encounter that was that they believed to put them at particular risk of HIV acquisition, they could go and get PEP. And some men did that on the study, but not very many. And that kind of tells us a story, I think, that we've been hearing for quite a long time, which is that it's really hard after the fact to really estimate what your level of risk was and to make the right call each time, because clearly men were having much more high-risk sex than they really recognised on this trial. Of course, the other really important message from this trial was that the men who really took their pills had a much, much higher level of protection than the men who didn't take their pills. And for those of you who haven't read this study, they've done all kinds of biomarkers to check that. The highly adherent people had a 73% reduction. And we've recently heard from the principal investigator of this study, than in people who really took their pills and had blood levels that you would expect of drugs. People who really were taking them every day had much, much higher levels. So what this study tells us is that PrEP really can work, but it only works if people are very adherent. And again, it's starting to tell you the same kind of story, similar to the one about antiretroviral therapy. It's pointless to try to coerce or cajole someone into taking PrEP. A person who goes on PrEP needs to be a person who wants to go on PrEP, who understands and believes that going on PrEP will significantly reduce his rate or his risk of HIV acquisition, and that therefore he's going to be prepared to take the pills in the way that he needs to take them to stay HIV negative. This is the news release from the HPTN 052, which was the study that just looked at putting people on treatment earlier rather than later. And this is where we saw that really amazing result of a 96% reduction in HIV transmission. But arguably, in the Australian epidemic, we've already had very high rates of accessing treatment. So apart from that funny little pink line that we saw before, where we could see people who were on suboptimal therapy, there may not be that far to go in terms of encouraging people to take up highly effective treatment. However, it is fair enough for a person with HIV, especially for someone who has opted so far not to take treatment, to look at these results and think, yeah, well, given that I can see that it does give me an edge in protecting my partners, and I do sometimes have unsafe sex, maybe that factor in itself makes it worthwhile going on. And it's a reasonable conversation for a person to have with himself, with his community partners, or with his clinician. So we currently have some dynamic tensions in the HIV prevention field. It can be hard to see, given the effectiveness of treatment as prevention, where the other strategies fit in. But in some ways, I think in the Australian epidemic, we can see that part of the epidemic is being fueled by people who don't know that they're positive. So by people who are probably having lots of sex in that period while they're seroconverting with very high viral loads. And that is kind of your niche there for PrEP here. There's also the question about the way that the prevention field goes forward now, whether we seek to optimise the strategies that we have, working out the perfect ways to target pre-exposure prophylaxis and treatment as prevention to try to stop ongoing incidence in HIV, or whether we're trying to actually develop new products. And it's important to note that the products that we have at the moment are very, very behaviourally dependent. So you're still going to have the same kind of support to keep a person effectively taking PrEP as you would have for, encouraging condom use. The kind of next generation question comes up about whether long-acting formulations can be devised that improve HIV treatment, as well as HIV treatment for prevention using strategies such as pre-exposure prophylaxis. In conclusion, I would put it to you that there are people who are at high risk of HIV acquisition in Australia who are not consistently using any reliable prevention intervention. And I think as a sector that we have a responsibility to those people, given that we have some new tools at our disposal now. It's my feeling that access to pre-exposure prophylaxis would help some of those people to stay HIV negative. But it's very much, we're talking about people needing to make quite individual choices based on the way that they're living their lives and the kind of sex that they're having at a particular point. I don't think there's any point of thinking of people as being, a PrEP person or not a PrEP person, more of thinking that you might have PrEP periods in your life. And you might have, condom periods in your life. And you might have periods in your life when you're with a stable partner who is on completely suppressive therapy. And these are all different strategies that might fit with you at different times, depending on the sex that you're having. And finally, I would say that teasing out the optimal use of these antiretroviral-based interventions together with interventions such as condoms and strategic positioning, the whole gamut of interventions that we've had so far, has now become a real ethical imperative as well as a scientific imperative. We need to understand how to use these things better, and that's probably an argument for having some kind of study involved in the way that we move forward.